All right, welcome. So I'm Dr. Joseph Finney. I'm Pediatric Emergency Medicine and EMS physician. I'm the Director of EMS at St. Louis Children's Hospital, and I'm here with Dr. Steve Laffey, who is a Pediatric Emergency Medicine physician at Cardinal Glennon Children's Hospital, and he's also the Medical Director for STARS at Cardinal Glennon. And we want to take a minute, this is ahead of a release of a position statement between our two hospitals regarding the use of naloxone in the pre-hospital setting for pediatric patients. And, you know, Steve, I've seen this a lot. I know you've seen this a lot. We are seeing patients come in who it's not that maybe it's a little bit misrecognized or that it's underappreciated or it's a little more subtle or it doesn't fit the exact sort of, typical toxidrome that you would expect for a fentanyl ingestion that ultimately ends up being a fentanyl ingestion. And so, I think our overall goal here is to encourage paramedics in the pre-hospital setting to utilize naloxone in children more frequently. And I don't know if you want to talk about, Steve, just a little bit about, what they can, are there any concerns, I should say, with using naloxone in children?
Yeah, I think, so as you were saying, what we're finding is a fair number of the kids that come in are presenting atypically. Sometimes dramatically atypically. I mean, I've seen kids that almost look like they were having seizures or increased tone instead of flaccid. We've seen a lot of that. The assumption always is, I think, it's probably because a lot of these kids do have multiple drugs on board, right? You get the drug screen back and it's
nothing's pure.
Fentanyl and ketamine and fentanyl and methamphetamine or cocaine and all this kind of stuff. So yeah, I think we're really trying, like I said, lowering the threshold. And as opposed to the adult world where you're dealing with, chronic users and risk for withdrawal, you really don't see that type of thing in the kids. So you're going to run into fewer problems, I think, with the Narcan in the pediatric world than you probably are. If you're thinking, we just had one recently where they were kind of considering it. We thought about it, but.
Yeah, right.
We thought about it, but wait, it was,
Talk yourself out of it.
Talk yourself out of it, exactly. And we don't ever talk ourselves out of it. We just say, give it.
Yeah, I think the mistake, that often happens, and we worry about this in the emergency department, is we'll end up giving naloxone, and it won't be the problem. And then there's kind of this feeling of like embarrassment, like, oh, I shouldn't have given it because that wasn't what was wrong. And, this is my own experience in the emergency department. A lot of times we are kind of figuring out what's going on by the way people respond to certain things, And so treating, and this is my sort of overall point is, when you've got a pediatric patient in the pre-hospital setting who's altered, let's say they're somnolent or maybe they're hypoventilating a little bit or, bradycardic or something like that that's just off about the patient. You've got to think about a couple really important potential diagnoses. And number one on your list, number one or two, has to be the possibility that that was an ingestion. And, the other big one you got to think about is the possibility that that was non-accidental trauma or a head injury of some kind. And, how are you going to differentiate those two? Well, if you've got a profound head injury and you give them naloxone, one, you're not going to harm them in any way. And two, you're going to take off the number two potential diagnosis off your list. And now you're traveling down a route of, okay, this is almost certainly, or at least my highest concern is that this is non-accidental trauma and a head injury. Now where I take that patient, how I manage that patient changes significantly. And if you give it and they feel they wake up, then you're in a much better situation. Okay, I'm not as worried about head injury. It could still be there, but if I can get that patient back to a relatively normal mental status, I have a good idea of what I'm dealing with. So in the adult world, when we've got the 75-year-old or the 50-year-old who's at Quick Trip, who's overdosing 3 times a week, it's a different sort of thought process of what am I using the naloxone for? I'm using it to make sure they keep breathing in that situation. With children, you're really using it to identify what's wrong with that patient and help that guide sort of the next steps. I don't know if you have any comments on that.
We call it diagnostic therapeutic, right?
Absolutely.
You're doing two things. You're not only treating the problem, but you're also diagnosing the problem by giving it. And we do that, like I said, we do that all the time. Be the guy who gave it in the field and has them wheeling in looking great.
Yep.
Don't be the guy or gal that wheels them in and has to watch us 5 minutes later give them it and turn them into great.
Right, right.
Because I've seen that, and then you're like, oh, yeah. Golly.
Absolutely. It's such a great point. And, people will worry about dosing.
Yeah.
Again, they're not habituated. So here's two caveats I want to make. if you've got a patient that you respond to who is a, bone cancer, who's been fighting it for 10 years and is on chronic opioids, be careful about that patient, pediatric or adult. The worst thing you want to do is put that patient in withdrawal. The second patient is a baby that is born in front of you to a mother that you're concerned is using some sort of, illicit drug or something like that. The last thing you want, other than a preterm, pre-hospital delivery, is a baby to start seizing on you in front of you. So you really want to, then you're just, it's NRP, it's managing ventilation in those patients. Outside of those two scenarios, naloxone is safe. It's safe by a variety of routes. It's safe, if you get to a child who's never had exposure to opioids before, there's almost no, I never say never, but very, very low risk of any adverse events. So it's a very safe medication. I don't want you worrying about trying to look up, okay, is it 0.1, is it 0.2? You can just give them a dose, see if there's a response, and if there is, terrific. If there's not, you move down your algorithm to think about other things.
Yep, I agree.
The other thing I want to talk about a little bit is the use of naloxone in cardiac arrest. This is getting a lot of attention in the literature now, and I would argue that it's pretty unclear whether there's any real benefit there. Steve, you teach PALS all the time. My opinion on this, and again, this is an opinion, after reading through everything, my opinion is that, sure, if you've got a patient in cardiac arrest, you can try naloxone, but it should be after you have done all of the necessary pediatric resuscitation algorithm steps. Because why are you giving that naloxone, right? You're giving it to reinstate a respiratory drive. If you've got a patient in cardiac arrest, you should be managing that respiratory drive yourself. So there's some thought that there's some other physiologic benefits that have not been proven out yet, and so are very, very much still in the research phase. Your job is to treat them the way you would a typical cardiac arrest, and if you've got someone with an extra set of hands, by all means, they can give a dose of naloxone.
Yeah, absolutely. As long as you're not foregoing something else on the algorithm. And I'm not as up to date on the research that you're talking about, but if you give someone an arrest and perhaps not asystole, hypotensive bradycardia,
right,
and you're working that code, and you give Narcan, and it makes a huge difference. What does that tell you? All that tells you is you weren't managing their airway properly, right? That's all it tells you.
Yep.
Narcan doesn't do anything that a bag and mask can't do. It does nothing that a bag and mask can't do. So if it ends up being your friend and it really turns things around, you're gonna have to look and say, why wasn't I already doing that? So, and I've heard stories, I've heard a couple of cases like that, and people are like, yeah, but I had this case, and you don't want to totally shatter them. But it's like, all that means is you weren't bagging them before you gave them the Narcan.
Well, this is where, beware of anecdote,
right, absolutely,
being evidence. And that's what I think is that everybody's going to have a story about a cardiac arrest that they gave naloxone to. And I just think our ability to identify some of the more nuanced characteristics of arrest, like low flow states and things like that in the pre-hospital setting, is still
really
developing. Yeah, and so I think I would just be careful. I would lean on the evidence and our overall take-home message, and like I said, this is going to go out in conjunction with a letter sort of summarizing our expectations from the children's hospitals, is know that it's safe. It's safe in the pediatric population outside of those scenarios I talked about, and it should be something that if you're dealing with a patient with undifferentiated altered mental status, pediatric patient who fits into that broad category, then you need to be having a discussion with your partner. Hey, do you think we should try naloxone? I think that's a really important thing to consider. And Steve, you said before we started rolling, if you're having a discussion about it, then you should probably be doing it. Yeah, exactly. It's like the should we give Versed, are they seizing, right? If you're discussing it, then you should be trying it, right? And so I think just giving you guys a little bit more confidence and support that is a safe intervention to try. And if you encounter obstacles when you deliver these patients to the hospital, Steve and I are more than happy to reach out and talk to the physicians involved and try and bring clarity to the situation, because I think we're all in it for the same goal. But definitely feel free to reach out to either of our institutions. We're happy to help you guys navigate this situation. But again, we just want to encourage you to use naloxone in those situations of sort of undifferentiated altered mental status in a pediatric patient.